Okay. So good afternoon. Thank you to all of you for being there for the last session in this room 2. It's a case of unusual PCI cases. My co-chair is Dr. Dat, who I worked with in the past, many times. And we have in the panel Quan Lee, Dr. Kayaya, Dr. Tan, Dr. Van Vuck, Dr. Phi Hung, and Dr. Fauzi Yaha. So I hope I pronounced the names correctly. Yeah, I'm sorry for that. So the first case is case number 13. I don't know if this is a lucky number, but we will see. So it's Dr. Giang who is going to present the case, how to simplify complex lesion with hybrid PCI. Welcome to you.
Thank you. Good afternoon, ladies and gentlemen. Now I will share my experience when I PCI complex lesion to make I hope that to make every complex to be simple and easier. So as we know, when we do PCI with many cases, sometimes we have the situation like that. The bifurcation, not bifurcation, sometimes the lesion relate to not only 2 branches, but also relate to more than 2 branches. For example, 3 or 4 relate to distal ablation also for 3 situations like that. Well, 5 years ago, for my practice, I tried to stenting every big vessel, significant vessel. I have a lot of case with 3 stent strategy in the bifurcation, extend to left main. So the procedure makes a very long time, take a lot of devices, expose radiation, everything like that. So make me very stressful. Now I change my approach with some situations like that because we have some data, some experience with the DCB in bifurcation lesion. Look at the 10 child with more than 900 patients compared to DAS in the main bank and DCB in the side bank. And we see the outcome better in the DCB group compared to non-DCB group according to restenosis and TOF. Another data with compared to not so much, not a big bone, but with the 100 patients with the 2 stent strategy and another group with the DAS and DCB hybrids. With the outcome as a procedure with the better in 2 stent strategy according to minimum lumen diameter and ratio stenosis, better in 2 stent strategy, but 6 months follow-up with TAVI. The research shows that the better outcome to work DS and DCB hybrid about lower late lumen loss and higher minimum lumen diameter. Another report shows that the DCB in main bank and the side bank compared to both bar alone is better at 9 month follow-up. In 2024, with a child with a DCB BIP child from Chinese college, so the better outcome with DCB in the side bank and stent in the main bank better in the non-compliant balloon. So this case PCI 1 year ago with a female 62 years old with the hypertension come to our hospital due to non-STEMI with the the cardiac function is about 50%. The CIG show the detail left main directed to atrium of LAD circumflex with a big ramus near the atrium of LD L6. What do we do now? With the lesion in the RCA, we PCI it is very easy. And in the plan to PCI the left main bifurcation like that, I have to send strategy in circumflex and LAD by mini graph technique. And I leave the OM alone. And if it's occlusion, after that I will rescue by my experience. The IVUS, so I check IVUS, and the IVUS, so the lesion in the proximal LVD extend to the distal of the left main. And the LCX, so IVUS, so that the lesion near the atrium and extend to left main, and the atrium of the OM is quite free. Another stenting with the mini cross with D8 in the 3.0 18 mm. And after kissing balloon, after kissing balloon, you see the OM lost. The patient have chest pain and 80° in ECG acute. And another guiding catheter will insert in the left main, and another wide filter ETA to insert to the OM easy. And I use 2.0 15 mm semi-compliant to open at 12 atmosphere. And DCB 2.75 25 mm at atmosphere OM. And after that, I kissing in a pair. POT again. As a final result, quite good. And until now, we don't have time to check the ECG of patient again, but the patient are quite good. No symptom until now. The IVUS shows the atrium of the OM is quite good, acceptable. And the stent of left main LAD and LCX is very good. Another case, the patient go to our hospital due to the non-STEMI with a 44 years old male. The cardiac function is very low, 25%. And the patient has the lesion, the complete lesion as the middle of right coronary, but in the left side, you can see the distal left main extend to the atrium of LAD, the LAD with the slope low, and the ramus near the atrium of the LAD and LCD, and the circumflex is quite good. So in my plan, after PCI the right side, I go PCI the left side after some day. So I just leave the circumflex lip again in my plan. And I just put the stent in the left main to remote and midi cross in the LAD. It's my plan. Stent in right side is very good. I was to check before I have planned. It reimbursed is a big reimburse. It's a distal perimeter 30 and 33, and the left main is the 5.0 diameter. Circumflex is the free in the atrium and LAD after P-dilate. Is a soft automatus block. So to send status Z is a first plan, but unfortunately the circumflex have some dissection agent to circumflex and makes the down blood pressure, cardiac shock, and I have to use high dose inotrope to keep the blood pressure for the patient. And I use another wire to put in circumflex and pedalate with 2.0 15 mm to keep the flow in circumflex. Using Duy Phuong guiding catheter to make procedure easier because I have to do a lot of operation. So, to stent status Z with the midi cross in the left main OM, left main, remus, and LED. And another guiding catheter with the balloon inside the circumflex to keep it during procedure because I don't want to lose it again. After two stents finished, I DCB in the circumflex. After POT, a big dissection in the circumflex, and I wait for 5 minutes. After that, no slow flow, no symptom, no acute occlusion. I left it alone. And after 6 months ago, the patient go to our hospital check again, but no CAG. But the symptom will release and the cardiac function go up to 50%. So in my practice for DCB, I not focus about the how much dissection, how severe dissection. I just focus on the how the dissection can lead the brain slow flow or have a high risk to acute occlusion. And stenosis residuals at about 50%, not 30%. Thank you.
Thank you very much for your nice lecture and also to be on time. Your first case was very nice because there's a fistula to the pulmonary artery, a small one, and we looked at it together. So after stenting, the fistula closed down because often the fistula, the vessel wall of this fistula is quite fragile. So I think at the moment you just stented it, you just closed off the fistula. That was just a small observation. Any questions from the panelists? Comment? Yeah.
Okay. First of all, I would like to thank you very much for your two cases, very interesting. So for the second case, do you use any MCS to support for the patient? Because you do patient for left main. So do you use any device, for example, IBB or IBB standby or ESMO standby? Because I think the second case, we also worry because you do PCI for left main. So
thanks for your question. So it's a very important question for us when we do PCI with high-risk patient with complex lesion and with a very low cardiac function. So in my practice, when I do this one, I never use ECMO. ECMO just support to hemodynamic with the patient with a high dose intubate. So for this patient, if we want to support hemodynamic, I just use IIBB. So in this case, this time we don't have IIBB for support, and I believe that I can prevent the hemodynamics for this patient. But unfortunately, I never think about the dissection can compare to the circumflex and make the patient drop to the high shock. But lucky, I can control it by high dose of inotrope.
Thank you for your presentation. Your case is very complicated. And why don't you think about the bypass for the patient, especially some patient at 44 years of age?
Yes. For the first thing we will discuss with the heart team, including the surgeons. But the first case, patient and the family patient denied to PCI to ABC. In the second case, the surgeon denies because the patient had a lot of risk for the surgery.
So maybe I will ask a question. We all do these bed LVs with triple vessels. So I have a question for our, the man who knows all about the data. How do we revive and stitch all this today? What is your message for the audience?
I think, obviously, for both your cases were actually trifurcation cases.
Yes.
Even though I think your first case, you called it a bifurcation case and you didn't protect the OM, I think it would have been useful to protect the OM with a wire, the thing. So I think understanding that you're about to take on a trifurcation and having all the appropriate guide size backup, it was very elegant what you did with the two guide technique, and there's no data for that, obviously.
Yeah, okay. There's just sometimes we can use, we have a lot of choice.
Yeah.
Protect the OM
Yes.
or not. And I don't want to use or protect of OM first because we have to use a lot of wire to
Yes.
make it confused. That's why I confident that I can restore it if you lose again.
Yeah, but obviously, if you want to look at the data with these high syntax score patients at that age, and then your second patient, I think you said that the patient also had severe mitral regurgitation in the setting of low EF.
Yes, it's the first time if I have the using two guiding catheter, it's the first time I will protect the OM because we have two guiding catheter. We have one guiding for 2 ways, okay. But I just use when I rescue the OM.
But the second case, probably you could definitely make a much more stronger argument because of the presence of also valvular heart disease and severe mitral regurgitation, that surgery should really, really be considered.
Yes, it one short. We have a lot of options.
Yeah, I think we're running out of time, so I'm going to... Lots of comments.
Dr. Dutt, do you want to present the next speaker?
Yeah.
You can take the microphone there. Thank you so much. Thank you.
Thank you, Dr. Tran Tra Giang, for the first lecture, and the second lecture. I will introduce Dr. Yongcheol Kim for the case number 2.
Good afternoon, everyone. Today, I'd like to talk about the. Sorry. Where is? Yeah, I'd like to talk about the case of the stent ablation by OCT guidance. So let's get back to the 2018. The 62-year-old gentleman complained of effort angina and visited in other private hospital, and the angiography showed the severe stenosis with heavy calcification in mid-RAD, and the TAVI flow is less than 3. So angiography showed the intermediated stenosis in the mid-RCA. So at that time, his operator planned to perform the PCI using the 6 French EBU guiding catheter. Predilation was done with a 2.5 semi-compliance balloon with, you can see this dog bone shape, and the follow-up angiography showed the improvement of TAVI flow. However, during the stent implantation, we could see the underexpanded balloon, and the follow-up angiography after stenting showed the underexpanded stent, as you can see. So that time his operator tried to fix it, but it did not work. In PCI report, is the operator described like that, is the adjuvant dilation with 3.0 millimeter NC balloon was performed at 22 atmosphere for 20 seconds for 11 times, but it did not work. So final angiography during the index PCI showed the residual stenosis with underexpanded stent and the TAVI flow. 1 year later, he visited the clinic in the previous hospital due to the recurrent angina, and the angiography showed the severe stenosis with the ISR of underexpanded stent in the mid-RAD with the TAVI flow less than 2. There was no interval change of the intermediated stenosis in the mid-RCA. The compare with the final angiography after stenting 1 year ago, the angiography showed the aggravation of the stenosis in the underexpanded stent area. So operator again tried to fix it using the small size balloon to the cutting balloon, but result was not happy, as you can see. As we expected, his patient complained the continuous effort angina, and finally he visited the outpatient clinic in our hospital. So after review of the previous angiography, I plan to perform the PCI via femoral approach using the A-French EVU guiding catheter. So pre-PCI OCT pullback was done. It was difficult to see the distal segment of the stent, but we can see what's going on the underexpanded stent area. OCT clearly showed that the mean stent diameter in the underexpanded stent area was between the 1.24 millimeters and the 1.66 millimeter, surrounded by 360 degrees of thick calcium. In addition, the 3D rendering image clearly demonstrated the underexpanded stent area, as you can see. So we decided to perform the stent ablation using the rotational atherectomy. At that time, the IVL is not available in South Korea, and we selected the burst size from the 125 and the 1.5 and the 1.75 according to the stent diameter in the underexpanded stent area. So after successful serial rotational atherectomy, is a follow-up angiography showed the increased lumen diameter in the underexpanded stent area. So I'd like to show that reality of the post-atherectomy OCT pullback image in my case. Image is not ideal due to that time is the OCT catheter get damage. But we could find out the clue of the successful stent ablation by very nice blood clearing. So OCT showed the no visible strut area in the site of the previous underexpanded stent with the fracture of the calcium and increased the lumen diameter to the 1.7 millimeter, but minimal lumen area still small, the 2.27 square millimeters. Therefore, POBA was done with the 3.0 millimeter NC balloon at up to 24 atmosphere, and the treatment with the 3.0 millimeter DCB at up to 13 atmosphere for 60 seconds. So final angiography showed the no residual stenosis with the good distal flow, but we could not achieve the final OCT because of the damage of the OCT catheter. So we are happy to share our experience regarding the successful OCT-guided stent ablation. There are several algorithms for the management of the calcified lesion, as you can see, and all algorithms highlight the use of the intravascular imaging. So I have to say that the intravascular imaging modality would be mandatory for the PCI in patients with heavily calcified lesion. So scoring system can help us to predict the stent underexpansion. So one thing is derived from the IVUS and the scoring calculated by the calcium length and the calcium, circular calcium and the calcified nodule and the vessel size with basically over the 270 degrees of the calcium arc. And regarding the OCT drive, the calcium scoring system was calculated by calcium arc more than 50%, vessel arc and the calcium thickness more than 0.5 millimeter, and the calcium length more than 5 millimeters, called the rule of fives. So I think that the IVUS is like a headlamp, and the OCT is kind of the scouter, which can see through the calcium itself, detecting the calcium thickness. So what is the most important step on the PCI for the heavily calcified lesion? I think that the crucial evidence for the successful calcium modification is the calcium fracture confirmed by OCT or IVUS. So we all know that the imaging optimization criteria from the 2018 EA-PCI expert consensus. However, many randomized data regarding the IVUS or OCT has been published since 2018. So 4 months ago is BK Kim, who was the PI of the OCCUPY trial, and me published a review of an article regarding the image guidance in the JACC Asia. And in this paper, we summarized the intravascular imaging guided stent optimization criteria in the randomized trial in terms of the stent sizing, landing zone, stent expansion, is the opposition or edge dissection. And finally, we are happy to provide a new version of the imaging optimization criteria data from the Ultimate trial, Renovate Complex PCI trial, Octavus trial, Illumian 4 trial, and OCCUPY trial as well. And I think that it is very easy to apply this in daily practice. It's actually, we put this, the optimization criteria is under the OCT device. We always check this after OCT-guided or IVUS or nearest IVUS-guided PCI. So in this year, ESC guideline recommend the image-guided PCI for the complex lesions, including left main and the true bifurcation and the long lesions. And I believe that the heavily calcified lesions should be included in the complex lesions. And don't forget to find the evidence of successful calcium modification, that is the calcium fracture confirmed by IVUS or OCT. Thank you for your attention.
Thank you very much. I think on behalf of Dr. Wee, we must thank you for coming all the way to this meeting. It's very important to have, the pioneers of, you have been publishing so many trials, important trials in interventional cardiology that you South Korean people are very impressive what you did. I think your point also in imaging is very important. At our site many years ago, there was indeed also a non-deployed stent, and my colleagues passed the wire just like that blindly and also went for rotastent. And basically the wire probably went under the strut and the burr could cross the strut, and it was impossible to pull out the burr, and the patient had to go for surgery and passed away. So I think the message definitely is, if you have an under-deployed stent, I think you agree, your wire can potentially go under the struts. A 125 burr will probably cross, but it will never come back. Yeah. So that means surgery. You agree?
Thank you.
Any questions, comments?
Yes. Great case, Dr. Kim. I would like to remind myself and others as well, in dealing with the calcified vessel, sometimes the minimal lumen area is not the most severe calcified. Sometimes in the proximal part of the distal part. So when we are notify this kind, using intracoronary imaging, we have to debug all the way. Sometimes we already can expand the minimal lumen area, but we forgot that we have to debug the proximal of the distal part. So the stent is not underexpanded in the proximal of the distal part. That's problem. And the second that I want to comment is this case is we do understand well that the cause of insulin restenosis is the mechanical problem, which is underexpanded stent. So at that point, maybe IVL will work, but some center doesn't have IVL. But if you are using a rotational atherectomy, is it might be not such a numbers, three burring, right?
Yeah.
Three burr.
Yeah.
1 to 0.25, 1.5, 175. For such situations, maybe one bury with a 175 will work. What do you think about that?
Because it's this case is one of my first case to get a stent ablation. So I just make sure it guarantees the safety. So that's why I try to perform the stent ablation by the 1.25 burr, because particle is the smaller when I use it's a 1.75 burr. So I really want to step up from the 1.25 to the 1.75 to make sure there's a patient safety. Yeah.
I fully agree. Basically, before IVL, we did it too. We call this rota stent, and we really have to upsize, because you can measure your MLA and you will see that the 1.5 will not cross. We had cases where the 1.5 doesn't cross. You have to go to 1.25 and then really step up. It's safer, and probably the rota stent effect is more effective when you upsize with different burrs. Yeah. I think you agree, yeah?
Yeah. So during the stent ablation, patient vital sign is absolutely okay. So I believe that I started the rotation stent ablation by the small burr. Yeah.
What rotation RPM do you use when you? Is it the same? Do you
Yeah,
use
normally I use the 180,000.
180.
Yeah. Yeah.
And then I think the primary mistake that the operator made was when they pre-dilated, there was a clear dog bone that never resolved. And when you see that, you should not implant a stent until you see it go away. I think that was the fundamental error that this operator made. And then I noticed that when they first tried to expand the balloon, they used a cutting balloon.
No, it's a semi-compliance balloon.
Or semi-compliance, but then they went to a cutting balloon like later on.
Yeah.
I've never seen a cutting balloon work under these circumstances before. It's either laser bombing or lithotripsy or stent rotablation.
I think that time is the operator worked in the private hospital. There is no option to just choose this scoring balloon to expand the stent, I think.
One other complication that I have seen a few times is torsion. When you deploy the stent, some stents will have torsion, and when you can try to rota stent or whatever, treat them by lithotripsy today, but there will mostly have stent fracture that you have to treat by a second stent. But I've seen a few cases where there is really torsion on the stent. And of course, this was an Orsaro, which is not the most... It's a good stent for some indications, yeah.
I have last comment. As I read on data about a doctor from Hungary, they do about 12 cases of rota ablation, but the result not so good. 50% have mace, and 25% death of any reason. So in your case, after you rotate ablation of a stent, why don't you use the stent or to confirm the result? I don't see the result, the choreography final, is right?
Yeah, so that patient is we just to follow this, the patient is really happy with on the OPD. We don't have any follow-up angiography at that time. Yeah.
Can I ask another technical question? When you started...
sorry, it's just my only one case. Is it just to remind you?
Yes. But no, I'm curious. When you start with a 125, do you then test with a balloon to see whether it can expand? Like, how do you choose to stop? Let's say you do a 125 and then you do a 1.5. Is it worth testing with a balloon at that point to see whether it expands?
The OCT is clearly show that the minimal stent diameter, in the underexpanded stent, and we can see the EEL. So that's why I just increase up to the 1.75 and then just the follow-up OCT. Yeah.
It's too bad that you had catheter damage. It would have been very interesting to see the 3D version of the stent after you rotablated. It would be so nice to see that.
Thank you.
Okay, do we have to go? Just a question to is Dr. Merida online, or so there is no case, okay? And is it okay that we discuss, so then we don't have we can have a final discussion? Okay. You want to introduce the next speaker?
We will move to the next speaking tip and trick to deal with heavy thrombus burden in STEMI with Dr. Duy Phuong.
Good afternoon, Chair and everybody. Today I'm honored to present the tip and trick to deal with large thrombus burden in STEMI patient. We know the STEMI we show every week, every day, and the problem is the occlusion, the artery. But the key of the STEMI is revascularization as soon as possible, very quickly, and for management of the STEMI, we have to choose combine the time revascularization, antithrombotic therapy, and the concrete present the revascularization, and combine all of the technique to approach the patient. But different from the patient of the STEMI. In the STEMI BCI's case, we focus to treating the concrete reason, and the main goal is restore the flow of the artery. The best flow is the TIMI3, and we stabilizing the patient more important than the perfect the coronary imaging, and very important. In the patient, we know when we stop the procedure as important. And the large thrombus burden in STEMI in the affected artery can cause serious issues. The distal embolization, microvascular obstructions, slow flow or no reflow phenomenon. And this problem leads to heart dysfunction and permanent damage, affected to the treatment crucials. In the total trial, show the large thrombus burden lead to worse outcome, and the patient with the higher thrombus burden have the higher 1 year death, especially with the heart failure or the cardiogenic shock. The implies the need for the carefully thrombus management. And the TIMI thrombus stress we show after the guide wire or the balloon crossing, the grades 4 or 5 is the large thrombus burden. And on the patient have the thrombus total occlusion is not the large thrombus burden, because the before the wire of balloon crossing, 56 the patient with the large thrombus burden. But after that, the wire and the balloon crossing, we show reclassifications have the 28 the patient with the large thrombus burden. But the strategy for managing large thrombus burden, when we crossing the TIMI flow 0, the routine use the thrombus aspirations, or we use the balloon redilatation. What should we do now? The approach the thrombus burden, we show the first is the thrombus burden is no thrombus or small, we can stand direction. But the large thrombus burden, we have the 3 cases. The crossing balloon, after crossing balloon, we see the landing zone, and we use the stand we use the stand direction. What's the crossing balloon technique or direct stenting? In the meta-analysis with the 12 clinical, the direct stenting group associated with the significant reduction in the short-term MACEs, 1 year's mortality, and no reflow phenomenon. This is the reason the direct stent identify the thrombus burden crest, lesion, and landing zones. we see the first situation is the patient male 56 years old, severe the stenosis in the mid LAD, and the total occlusion, the RCA with the thrombus, and we show the primary RCA stage. After that, we PCI LAD. After wiring the TAVI flow 0, we use the reduced balloon across the thrombus, and after the balloon across, we see the landing zone appear, and we choose the biggest stent and longest in the proximal RCAs. And this is the result. What is the crossing balloon or dotting balloon technique? When we see the thrombus occlusion, the vessel, we wire across the occlusion. We use the deflex balloon or the small balloon or reduced balloon to cross the occlusion. And the balloon across the thrombus go to the distal. We pull back the balloon, but when we pull back the balloon, before the occlusion, we inject a little bit contrast to protect the thrombus can going out the vessel. And after, if we see the landing zone, we stenting if possible. It's the tip and trick to the dotting balloon. In the practice, a case with occlusion in the LAD, after wire crossing, the balloon crossing, and we see the landing zone with direct stenting. The result is the flow is 2 to 3. Another cases with the occlusion in the middle, in the distal RSAs, wire and balloon crossing. After we see the landing zone, and we direct stand in the distal to the BL. It's the result is 3. But if the after the crossing balloon, the large thrombus is too much, or we can't see the landing zone, we use the thrombus aspirations. In the thrombus aspiration, can use the large residual for the residual thrombus burden after the opening vessel. If the thrombus burden, the thrombus burden aspiration may be considered. In this case, the total occlusion in the middle RSA with the large thrombus burden. After wiring, we see the distal RSA, but the thrombus too much grade 4. If we choose the stent, very long stent, and choose the aspirations, after aspiration have the too much the thrombus, and after that we see the landing zone appear, and we choose the short stent. And this is the result. This is the result after stenting. But we can have the keys because when the aspiration, the thrombus is a little too much, we can deflate the PCIs. But defer the stenting is not the routine surgery for all of the patient, STEMI patient. We can use, in the case of high thrombus burden, longer lesion, high risk feature for slow flow, and those with the suboptimal TAVI after thrombus aspirations, and use the dual antiplatelet and peripheral anticoagulant. The time differ up to the 5 to 7 days. Have the prevent to be safe and are the advocated. In the situations, the patient have the old stent in the RCAs 4 years ago, and now have the again STEMI day 3 clip 1. In the angiography, which we show the occlusion in the total in the proximal RCAs. But the wiring after the crossing balloon and TAVI is very low. We use the balloon 2.5 and NC balloon 30 and thrombus ablation many times, but the thrombus is too much. What should we do now? Redirect again, aspiration again, stand or stop. And now in this case, we choose the stop and wait a week. In the times after the week with the enoxaparin and DVT, we check again the angiography. We show the small the thrombus is smaller, and the thrombus is smaller and have the restenosis in the stent in distal RCAs. We pre-dilate with the scoring balloon in the distal stent and choose the biggest stent in the middle RCAs and DCB in the priority stent in distal RCAs. And this is the result. Is the TAVI is the better. And conclusions. Managing large thrombus burden is the primary PCI remain the challenges. Complications include the distal embolization, no or slow reflow, or embolization into the non-conquest vessel. No single-ID trachea exists. But management must be individualized based on patient condition, the operator expertise and experience. Thanks for attention.
Thank you very much. We have time for questions. I think if I ask the question how you aspirate, you will have 10 different answers because we are about 10 people here. Everybody's doing different style. Yeah? So, Dr. Dutt, what is your style when you do? Maybe you can ask a question first, sorry. Yeah. It's on.
Yeah, thank you. Thank you for a nice presentation. So the large volume of thrombus is our enemy. So right now in Japan, we use a perfusion balloon for such lesions. So I don't know if you have a perfusion balloon here, but we used to use a perfusion balloon for just for the bailout for rupture or perforation. But nowadays we use a perfusion balloon for large thrombus burden, and we can keep a distal flow during balloon dilatation, and we can use a long inflation, like 2 minutes to 5 minutes. We can inflate for a long time, and we can still restore the distal flow. Then after that, sometimes the thrombus burden is getting lower. So that is a option for a large burden thrombus.
That's a good point. Yeah, Quan?
I think, sorry, did you want to go?
Good afternoon. I'm Dr. Sơn from Gia Hospital. Thank you for your very interesting lecture. So I would like to ask about the tips and tricks to aspirate the thrombus. In some cases, when we try to aspirate and then we use a balloon from a small balloon to bigger balloon, but we cannot aspirate. How can we do it next? In my center, sometimes we use the fibrinolytic with small dose to inject to make it to small particle, and after that, sometimes we can aspirate everything. And like in your lecture, when you see the distal flow, so you try to put a stent, but in our experience, sometimes the large thrombus burden come to another place. So sometimes when you aspirate everything, the coronary artery may be sometimes very normal. So I think that instead of trying to put a stent, I think that it's better to aspirate everything before you decided to put a stent. Here I would like to ask about the experience of using small dose of fluorolithic to inject to make it easier to aspirate.
Yeah, I think in my experience in high thrombus burden lesion that's resistant to, reperfusion with ballooning, etc., I find that small dose thrombolytics intracoronary actually work very well. The main thing about using it is you need to give it time. When you inject it, you have to wait for a while because it takes time to act. I've had it work very effectively in some cases. I don't tend to aspirate at the same time if I start to get flow back in because it breaks up into a lot of fragments and your stroke risk theoretically, depending on what you're doing, might be higher. We have moved away from aspiration thrombectomy to mechanical thrombectomy with CAT RX at this point. We no longer use aspiration thrombectomy because one of the tips and tricks is that if you're working in the LAD or the circumflex and you're just using aspiration, sometimes the thrombus from the circumflex will go into the LAD or from the LAD in the circumflex. If you're working in the RCA, it's not a problem because it's just one vessel. But then if you don't aspirate carefully right at the end, you can also cause a stroke. So that's another big thing. One point I wanted to make is earlier is the use of IVUS under these conditions is actually very, very helpful. I've had it where I balloon and I get zero flow, and I don't know where where the end is. If you stick an IVUS down, you can actually see where your end should be, and you know exactly what size your stent is. And then you know approximately exactly what your stent is. And the next move, instead of trying to aspirate, I've actually stented with IVUS sizing across the region and had complete resumption of perfect sizing and flow. So that might be part of what the benefit of ultimate ACS was.
You're using the penumbra coronary device now, or because of course this is expensive and it's probably still an issue for other countries. Maybe you, sorry.
Yeah, we've also used angiojet before. It also works.
You can finish and then you, 1 second. You have some more question? Yes.
I think that because to put a stent is okay, but sometimes we cannot satisfy because maybe the patient has maybe no lesion. So the problem is we try to aspirate. But I think that there is another tips to determine the distal flow by we can inject into the aspiration catheter to the distal, and we can see the distal flow, and we can define the distal diameter. But I think that the most important problem is that we should aspirate the thrombus.
Mm-hmm. Even when you inject, sometimes it's vasoconstricted, so what you see is not real.
It always also depends on what you have locally, and I think for our Vietnamese colleagues, if you don't have the access to penumbra, you have to use what you have. You have a question?
Yes, I have a question. Thank you very much for your presentation. And I have a question that when we put the direct stenting in the plaque with a lot of thrombus, so I have two problems I need to concern about. That is the thrombus protrude through the stent, through the stroke of stent and through the edge of the stent. So do you think that is the problem can cause the thrombus inside the stent very soon? And the second thing, the time lapse, the thrombus is stuck in between the layer of the wall artery and the stent. So the time lapse, the thrombus destroy and it can release the empty space there. So should we advanced patient come back and we do angiogram and we NC balloon again?
So there's two very simple questions. You want to answer the questions?
If the large thrombus, but I think the question of Dr. Cheung is when the occlusion, the goal target, the first target is the reflow. Reflow is the very important. if we have the flow in the vessel and the patient have the stable, we can wait times maybe 3 or 5 days and check again. Because usual is the maybe no the stenosis, okay, stenosis, only the thrombus. But the question of the question is if we use the thrombus inside the stent is the I don't worry this because I choose the use the IVUS to check the through the lumen this diameter of the vessel, and we choose the diameter stent, and we choose the longer, a little bit longer. If we measure is maybe 20 or 25, we can choose the 33 or maybe 38 for longer stent.
Yeah, thank you very much.
You want to make a comment? Yeah.
One comment quickly. Yes, I think in direct stenting, in our center now, when we get the square through the lesion, okay, after that we do brutally IVUS to make sure the diameter and everything. So in this case, you showed us direct stenting with the very big one, 4.0. So it's deep, very bigger. So I just worries about the landing zone distal. Also worries about dissection, also perforation. So maybe sometimes I think it's harmful. Yes, just come on, little bit look like this. And sometimes we also use aspiration, phlebotomy. Sometimes, okay, go ahead with balloon. It depends on the patient. It depends on the how large burden of thrombus. After that, we make the decision for the patient. I think it's good for the patient now. Yes.
Okay, thank you very much. Thank you very much for your nice lecture. Dr. Dutt, you have the honor to announce the last presentation, if you agree. You need to get the microphone back.
Now we move to the last presentation with Dr. Dinh Huynh Linh. TAVI procedure, another unplanned intervention in the same index. Should we do it differently?
Yeah. Good afternoon, Mr. Chairman, ladies and gentlemen. It's my great honor to be here today to present my case about TAVI. It's not a very happy ending case, but I think it would be great to share all of the audience here my case. We have done not so many TAVI cases so far, just I think about 80 to 90 cases in the last 10 years, and we are still learning, and I think that all of us are still learning about this procedure. So this patient was admitted due to dyspnea and chest pain. You can see the troponin is elevated, so clearly he has the acute MI. The probinipy is elevated, and on the EKG, I hope you can see it well. We did not see the ST elevation, but we can see the Q wave in D3 and AVF. You can see the right bundle branch block, ST depressed in V5, V6. We did the echo, and you can see that the heart function is very poor, just about 20 to 30% VF, and the patient get worse, and we had to intubate him. So the diagnosis is a cardiogenic shock. A patient with non-STEMI with CVIS, and the SDS score is very, very high. I can show that. Because the patient has acute MI and even the patient has AS, so we perform angiogram. And it will be an easy decision for us if you can see clearly the corporeal lesion. But you can see here, there is not a very clear corporeal lesion. Yeah, it's a headache for interventionists. You don't know where to do the PCI. So So our first question is, what can we do? We do the cabbage and we do the surgical AVR, or we perform PCI and then we do TAVI and then PCI, or we do TAVI and PCI at the same time. The problem is that if we want to do the coronary revascularization, we don't know the complication. There's some hazy in the mid-LED, but we are not sure that it was the complication. The circ looks not very good, but it's not very bad. The flow is pretty okay, all of the 3 vessels. Okay, so we know that PCI before, with TAVI, and after TAVI all have pros and cons. So it is a very nice presentation presented in TCT 1 month ago. So after a long discussion, we decided to do the TAVI. And when we say that TAVI, then PCI, mean that we do the TAVI first and we want to improve the hemodynamic status of the patient. If the patient is okay, we may stop to do PCI. But if the patient gets worse, we may consider to do PCI. So it is our choice, and I hope that you agree with us. We can discuss with it later on. Okay, so we performed the multi-slide investigation before TAVI. Eric, I know that the screen is a little bit small for you, but you can see it is clearly a tricuspid aortic valve. You can see the very severe calcium in the annulus, but the SOV is quite good, so the diameter is from the minimum diameter SOV is 32 and the maximum is 35. I think it is sufficient, large enough. And we can see the area is 600 millimeters square, so it's quite large. The perimeter is 88 millimeter. And the plane to coronary is 12.8 for the left and 11 for the right. So it is borderline, especially for the right side. So the next question is what kind of TAVI valve should we choose? We should choose the balloon expandable or cell expandable, and the size of the heart valve. We know that we may need to do PCI later on, maybe 1 month or 1 year later, and pretty low VTC height. So we do think that balloon expandable is a better option in this case, and based on the analysis, with the area is 600 millimeters square, we chose the 29 millimeter S3, and it will be oversized by 8%, and the peripheral access is pretty good, so you can do transfemoral. Yeah. So the TAVI strategy, we go transfemoral. The patient is already intubated. We can use TT guidance as normal, but TE is backup. We consider not to do balloon valvuloplasty first because it is a tricuspid and the hemodynamic was very unstable. We are not sure we will do the very rapid pacing. The hemodynamic may be deteriorate. We are not sure if we should protect the coronary artery or not. But we think that we really wanted to do this case fast and simple because this patient was very sick, very unstable, and based on the analysis, it is the virtual planning performed by Edwards analyst. So we think it would be safe if we aim the valve a little bit lower than normal, maybe 80/20. So we decided not to do any BAV, no coronary protection, and we aim the valve a little bit low. So it is a TAVI procedure, so quite smooth. You can see that we try to aim the valve a little bit low, but then when we inflated the valve, I don't think it was 80/20. It is a little bit like a 90/10. But it looks pretty fine for me, and you can see the aortogram here. The coronary flows was still okay, yeah. So we are okay, happy, And we check the TTE and left heart catheterizations, the good hemodynamic, not so much gradient. But 5 minutes later, the patient developed bradycardia and hypotensive. And the aortogram revealed occlusion of the RCA. And we can also notice some leakage from the annulus to some heart cavity.
Can we see the previous view? Because,
Yes, please.
Yeah,
you
this
can see.
one more back.
You want to see this one?
Yeah, this one, yeah.
So this one, we did not notice some hazy here, maybe some leakage is here already, but we did not notice it. But the RCA was okay at that time. Yeah. Yes. So at that time, the patient was very stable. We decided to stop. We are happy. We checked the echo. We checked the gradient, and you see okay. Yes. So you see the gradient is quite good, but then the patient has brady, hypertension, and the RCA is gone. Where was it? So I think my first thought was that some calcium may block the RCA. I think that. I don't know. I have no idea. But we need to do something, and we do the R4, and it was quite easy, just 5 seconds to cannulate the RCA, and we do the selective angiogram. We reveal the total occlusion of the RCA, some disease at the ostium of the RCA. So please remind that at first the RCA looks nearly normal, and we get the guide wire to the RCAs quite fast. Yes. We do the ballooning, and we can restore the RCA flow. Yeah, no matter what was the cause, we had no idea what the cause is, but we need to restore the RCA flow. So we restore it, and we thought we needed to stent it. So we put a Zions 35 by 28 on the guide extension. The reason why we used the guide extension because we had no idea, maybe the stent structure in block partly block the RCA, so it is safer to use the guide extension so that we did not dislodge the stent. So we put we stand up to the ostium RCA, and quite fast and simple, and it was not a problem. Yeah, and do the post-dilatation up to the aorta. And this is the final angiogram, quite good. Yeah, are you happy? Yeah. So the second question is about how about the leakage now? What can we do? What can we do with the leakage now? We had no idea. Maybe the leak. Yes.
So did you consider at some point to do an echo to see the pericardium?
Pericardium?
Yeah.
We did. We did the. I cannot control it. Maybe some technical issue here. Em có thể chỉnh cái file nó không chạy nữa. Yeah. Đây là một it's the most interesting part of the case.
Wow. Yeah. And
okay.
maybe go one slide back. Then we can...
Em đang chỉnh nhá. Okay, so we did the TEE. Yes, because the patient is already intubated, so we did the TEE. Yeah.
Because of course there could be, but if it's partial annular rupture, then that could be okay.
Then some effusion.
Yeah.
That is very true. Yeah.
It looks like he got into right atrial. Yeah, it's going into a kind of cavity which we don't know what it is.
Yeah. Em ơi, nó bị che. Oh, sorry. So we did the TEE. What I can tell you that we lost the TEE images, so I could not show you now because it was in an acute phase and everything was like a mess. But my echo said that it is the leakage from aorta to NV. It's like the MVOT, something like that, but very tiny. So, yeah, em ơi. So, okay, so I think we can, no effusion, everything is fine. So I don't know what would you do, Eric, and yeah, other doctors. I didn't know, I had no idea what we do, but we decided to stop because the patient is quite stable. We get a good coronary flow, the hemodynamic is okay, and the leakage is very tiny. We stopped. And we decided to do the multi-slide CT after that. Okay, so while they are fixing it, I can tell the consequences of this case. But the patient had acute kidney injury, very severe kidney injury, so because cardiogenic shock. So the multi-slide CT was pending. But after 3 days, the patient developed very bad hemodynamic and he passed away. Okay, so it's not a very happy case to show you. So my question is that even that if they cannot show you, I think we get enough information to discuss now. What should we do differently? Should we try to do the coil or plug or anything to occlude the em này quay lại hình trước không? Anh chỉ cần cái hình trước thôi. To occlude the
I see your
leakage.
point. Yeah. So basically, this is a complication I've seen a few times. Basically, it's the fistula between the ascending aorta and the outflow tract because of a calcium spicule that is, creating a kind of fistula.
Yeah.
That creates a high flow situation, of course. But I think your patient was very sick, so I think you did everything you had to do. But potentially, even that the calcium was the reason. Calcium, very heavy calcium caused the fistula, and potentially also played a role in the occlusion of the right. Probably it's both. Yeah.
Yes. Thanks, Eric, for that.
I have a question. If the fistula is to the LVOT, why is the contrast going in the opposite direction? The LVOT should be coming this way. I think this is a aortic to RA fistula.
Yeah.
It doesn't make any sense at all.
Yeah, I do.
The way you could have figured this out.
Looks like that. Agree with you. Yeah.
If you put a right heart cath up and just draw a sat from the RA to the RV, you would see the shunting, and then you know straight away, right?
Maybe you are right. Yeah.
The other way to tell is if you shoot this same picture in the LAO caudal projection. If it's really shunting into the left side, it will come left side. If it's going right side, it will go right side.
Yes. But should we close the shunting or not? Or should you leave it? Is my question.
You have to shunting left to right, you have to close it. The patient will never survive a left to right shunt.
Yeah.
I think absolutely you're right, Quan. The LV is on the other side, definitely in this view. And I also have seen fistula after TAVI from the aorta to the right atrium. So it also can happen. It's the same, yeah.
And definitely, it's not a surgical candidate, but if you want to do it transcatheter, what kind of device you can do, Eric? Can you give me some advice on that?
So we did a few. The last one I did a few weeks ago was as a complication of a failed transeptal puncture. The patient had a fistula between the non-coronary sinus and the right atrium. And so basically what you do, you go arterial, you just go with a thermo wire from arterial, from the ascending aorta, you basically snare it in the RV or in the right atrium, and you go from jugular. And then you just, mostly what I would use here probably is like a PDA device, a small PDA device. Yeah. But here it doesn't really matter what you use because it's whatever. But as Quan says, probably it's always so easy afterwards to comment, but it's probably this is the problem of the hemodynamic collapse. That's probably the point. You're right.
Yeah, maybe you're right. We were just happy that we can fix the RCA occlusion, and you see when we saw the leakage is very tiny. I discussed with Duy Phuong a lot to close or not.
That leakage is not tiny, right?
Because but the last time it was
No,
smaller.
but if you look at that on the picture on the right, just injecting into the coronary generates, and you're not injecting very much. There's so much contrast crossing over from that small injection that is not a small hole.
I had another aortogram, but I'm afraid that I could not show you. Okay, but I do agree with you that we should fix it. That is my main lessons that I learned from this painful case. Thank you very much. Thank you very much.
Very nice case.
Thank you. Thank you. Yeah. Okay.
And I think it's nice that you had a chance to CT size, even in the setting of cardiogenic shock. I was talking to the guys from Nanjing, and they told me that 30% of their TAVRs are in the set. No, actually, 20% of their TAVRs are in the setting of cardiogenic shock, where they don't use CT at all. Yeah. They just use TE guidance, and they just put the
really?
TAVR up without any kind of CT planning. So you know, it's nice to have the luxury of a CT to plan.
We are not that skillful. I cannot do anything without CT. Yeah. Thank you so much.
Yes, can I explain about this picture, because I think we just fixed the RCA, but not the original problem of this case. Actually, based on this view, you see that the flow from the aorta go directly to the RV. So that is the problem, that the valve, the stent valve already make the right coronary cut already rupture and make the connection to the RV. So maybe they check up to the atrium of RV and then lock the atrium of the RV. So we fix the RV atrium, is just make some flow to the RV and solve up the just small problem. But the whole thing is still there. So the patient collapsed 3 days later, I think. But very sorry about that. But we learned something from this case. I think so. Thank you.
Yeah. But anyway, I think it's a great case that you shared, definitely. And I even not sure if it would have been plugged that the patient would have survived. The patient was anyway in a very bad status. So don't feel uncomfortable. You can go home with a, peaceful heart, please. Dr. Dat, you want to make some remarks, closing remarks, because I think we are out of time. You want to say some words for the end? For me? No, I don't know. Well, I think we can thank all the presenters for being here and sharing the cases. I think there were really great cases, and we learned a lot from all of you. Thank you for being so honest to share your case from many places in Vietnam, and also from Korea. So with that, I think there is a closing ceremony in a room in the main auditorium if you want to attend, and if not, wish you a healthy and safe trip back to your homes. Thank you very much.